Yes, I'm about to watch something really, really good. My best friend, Amira Doogie Booty Hamid, live on the Doctor Show. Doctor.
And now, standing 5'3", a second-year phenom from your hometown Chicago, her dancing has been confused with an aggressive pseudo-seizure. Put your hands together for Amira Hamid!
Mira.
What's up, everybody? It's me, Amira, coming at you with the chapter on valvular disorders. First, we'll talk about what to do after diagnosing a new murmur, which is a really great topic because I think this is the only new bit of information we're learning in this chapter. The rest is just step 1 review. Next, we'll breeze through a review on valvular disorders, a quick factual fizz, clinical features, and helpful diagnostics tools, as well as treatments. Lastly, we'll briefly look at what we do with special caveats, i.e. prosthetic valves and pregnant women with murmurs. So, getting started, do you guys remember how to grade murmurs? That's right, I didn't think so.
Sorry.
Real quick so you can actually document what you heard. 1 and 2 are super low-key, with 1 being a little bitty faint murmur, and 2 still being quiet, but immediately heard upon putting the stethoscope on the chest. 3 is where things start getting loud, with 3 being moderately loud, and 4 being loud. Now 5 and up is where things start to get a little crazy, with 5 being so loud that when you take the stethoscope partially off the chest, you can still hear the murmur, and 6 being so loud that you can hear it with the stethoscope not even touching the chest. Obviously, the louder, the more concerning. Now let's jump into our algorithm on what to do when we hear a new murmur. So basically, the first step is to determine whether it's a diastolic or systolic murmur. If it's diastolic, then that's always pathologic, and the patient will need to be referred for an echo in the future. If it's systolic, then it depends on the severity of the murmur. Loud murmurs, grade 3s and above, will also need to be referred for an echo, while quiet murmurs, grades 2 and below, can be sent for echo only if they're symptomatic or associated with abnormal physical exam, EKG, or chest x-ray. If they're asymptomatic without any abnormal findings, then stop right there because no further workup is indicated. And that's that for diagnosing new murmurs. Moving right along to our second section, and what the majority of this chapter is about, the valve review. Starting with our buddy, the mitral valve. Mitral stenosis, of course, we know the most common cause, rheumatic fever, causing scarring, fusion, calcification, and limited mobility of the valve. This results in increased left atrial pressure, which leads to pulmonary congestion, pulmonary hypertension, blah, 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 essentially left heart failure, which can then be followed by right heart failure. Another complication is that patients can develop AFib due to the dilatation of the atria. Features of mitral stenosis include exertional dyspnea, hemoptysis from dilatation of the pulmonary vessels, and heart failure. Systemic emboli can also be seen in up to a third of these patients. Physical exam findings include that mid-diastolic rumble and a loud S1 as the mitral valve snaps closed. On EKG, we can see notched or biphasic P waves and right axis deviation. On chest x-ray, we may see straightening of the left heart border, indicating left atrial enlargement as well as signs of pulmonary edema, with treatment being diuretics and valve repair and or replacement. Sticking with our buddy the mitral valve, we're cruising right along to mitral valve regurg, which can either be chronic or acute. Most commonly being chronic is typically tolerated by the patient as it leads to a gradual onset of left atrial enlargement with simultaneous increase in the stroke volume. Normal cardiac output is maintained and the patients are pretty cool. Acute is less common, sudden in onset, and disastrous. All badness here. The valve oris components rupture, causing sudden backflow back into the left atrium, leading to immediate onset of flash pulmonary edema, cardiogenic shock, and possible cardiac arrest. Common causes include MI causing chordae tendinary rupture, papillary muscle rupture, or valve rupture secondary to infective endocarditis. Tintinellis also says that it can be spontaneous, which is extra spooky, y'all. As far as diagnosis, acute mitral regurg should be included in every patient with new onset pulmonary edema, but unfortunately is missed sometimes as the murmur may be inaudible due to the raging tachypnea and the raging pulmonary edema. It should be strongly considered if the patient does not respond to your conventional therapy or if an MI is noted, particularly in the anterior leads. So do yourself a favor, be a Dr. Cosby Baylitz, and place an ultrasound probe on that chest and check it out. As far as the physical exam, findings include high-pitched apical holosystolic murmur best heard over the fifth intercostal space of the left thorax. An S3 or S4 gallop may also be appreciated. On EKG, we can see left atrial enlargement and left ventricular hypertrophy in chronic mitral regurg. So what's the treatment? Well, for acute regurg, we're giving O2, we're giving nitrates, we're getting Lasix, we're intubating like the bosses that we are, if indicated. And your goal is to try to reduce the afterload to assist with forward flow from the left ventricle. Nitroprusside can be used for this. You can also add dobutamine and dopamine drips, which can be used for hypotension. And if it's looking grim, consider an aortic balloon pump to improve that forward flow. Lastly, in the setting of AFib, these patients will need rate control with heparin therapy, followed by warfarin therapy with an INR goal of 2 to 3, given their high risk for embolism. And just when you thought you couldn't get enough of the mitral valve, there's mitral valve prolapse, which is the billowing of the mitral leaflets into the left atrium during systole.
Amira, I seriously have got to give you props. That is a lot of stuff to know about. That's crazy. I didn't know it was that crazy. You get props. It's a lot of focus. Let's see where this story's going next. Got no input on this one. I'm not smart enough.
This can occur with or without regurg, usually due to the myxomatous degeneration of the mitral valve, classically in your Marfan's patient or your thin young woman.
I wonder, did you have to do this live or did you get to record it and send it in? Because you're killing this. Good job. This is crazy.
Is usually heard as a mid-systolic click and is not even associated with any increased risk of AFib, syncope, stroke, or sudden death. In fact, it's the most common valvular heart disease in industrialized countries. Patients may present with palpitations, anxiety, or chest pain. The treatment is reassurance unless it's associated symptoms or regurgitation present. If they're symptomatic, you can try beta blockers and ask them to refrain from all the fun stuff, all the alcohol, the tobacco, the caffeine. If they have risk factors for embolization, such as AFib, previous stroke, age greater than 65, mitral regurg, hypertension, or heart failure, then daily aspirin therapy is recommended as well. If regurgitation is present, then patients will also need endocarditis prophylaxis. Now that was a mouthful on mitral valves, but I promise the remainder is short and sweet. On to the aortic valve. Aortic stenosis. Features of aortic stenosis include the classic triad of dyspnea, chest pain, and syncope induced by exertion. Exam usually reveals a harsh systolic ejection murmur. A paradoxically split or single S2 may be heard due to the stiff delayed closing of the valve as well. An S3 or S4 may also be appreciated. Findings also include diminished carotid pulse with delayed upstroke and narrow pulse pressure. As far as the EKG, we may see some left ventricular hypertrophy. So treatment for aortic stenosis, if symptomatic, admit these people for surgery. These patients have a 75% mortality within the next 3 years. We can also use oxygen and diuretics to treat the pulmonary edema. And if these patients develop AFib, the result is catastrophic. The left ventricle is completely dependent on the diastolic filling from the left atrium, and when that's knocked out, they're going down like Ronda Rousey. This patient needs to be cardioverted and started on anticoagulation. Obviously, guys, this patient will need to be admitted. That's it for stenosis. Moving right along to aortic regurg. Just like with the mitral valve, this can be acute or chronic, with acute being complete and total badness, and chronic being not so bad. With chronic aortic regurg, a nice normal cardiac output is maintained. Acute aortic regurg is usually due to the sudden dissection, trauma, or infective endocarditis leading to sudden onset of left heart failure, poor cardiac output, cardiogenic shock followed by cardiac arrest. EKG most commonly shows left ventricular hypertrophy if the regurgitation is chronic, but it may also show a STEMI if an aortic dissection is the cause of your acute regurg. Treatment for chronic aortic regurg include vasodilators such as ACE inhibitors and nifedipine, typically began by the patient's PCP. DISPO is to admit any patients who are severely symptomatic. Now, as far as treatment for acute aortic regurg, purely surgical, and death is common. Resuscitation goals are to decrease the afterload with drugs like nitroprusside and increase the forward flow with ionotropes like dobutamine and dopamine. Of note, beta blockers should be avoided in these patients so not to blunt the tachycardia that the heart obviously needs to improve its cardiac output. Also of huge note, major key here, avoid the aortic balloon pumps in these guys because you'll be looking a plumb fool when you drown the patient in his own pulmonary edema by worsening the regurgitation. Alright, so now we finished with the aortic and mitral valves. Now for a quick line or two on the right-sided valve disease, which is a lot less interesting. Tricuspid regurg can be due to IV drug use, as we all know, usually secondary to Staph aureus, or it could be due to chronic lung diseases such as COPD, chronic PEs, or left heart failure. Tricuspid stenosis is usually due to carcinoid syndrome or rheumatic fever. Pulmonary stenosis is typically congenital, such as the tetralogy of Fallot, or can be caused by carcinoid syndrome as well. Pulmonary regurg is rare, usually secondary to pulmonary hypertension. Features include signs of right heart failure, which we all know includes JVD, hepatosplenomegaly, ascites, and lower extremity edema. Now for the final, the last, the ultimate section in the valve disorder chapter. First, a quick blurb on the prosthetic valves, and then all the pregnant ladies. Shout out to all the ladies in the program. Woo woo, representing for the PGY2 women right here on the podcast, channeling my inner Beyonce. Now back to these valves. Replacements can either be bioprosthetic or mechanical. The bioprosthetics are usually human, bovine, or the swine if that's your thing, and the pros are that they don't require anticoagulation, but they do fail more often. The mechanical valves require warfarin therapy, which is a bummer, and even with anticoagulation, the rate of thromboembolism is still 1 to 2% a year. Thromboembolism is more common with the mitral valve than the aortic valve replacement, so the INR goal for mechanical mitral valve is 2.5 to 3.5, while the aortic valve INR goal is your regular 2 to 3. Other complications of the valve include endocarditis, occurring most frequently during the 2-month post-op period, with the most common organism being Staph epidermidis, followed by Staph aureus. That damn Staph. Most common after this 2-month interval is strep viridans and bugs similar to those affected the native valves. Major key alert. In any patient with previous valve repair presenting with acute onset of respiratory distress, pulmonary edema, and cardiogenic shock, consider valve failure, massive valve clot, or torn bioprosthesis. Now let's switch gears and say that your patient is super therapeutic with their INR and they've been popping that warfarin like candy, or doing one of those million things that affects warfarin therapy, and you need to reverse their INR. Well, an INR of 5 to 10 without evidence of bleed should be treated by withholding warfarin and given 1 to 2.5 of PO vitamin K. Parenteral therapy should be avoided to prevent overshooting and overcorrecting. Now, if a severe bleed is noted, then obviously that goes the hell out the window and you slam them with FFP. Now for our very last section as far as our pregnant mommies. Remember that their cardiac output increases due to the increased stroke volume and heart rate. Their blood volume increases by like 50%, and they also have less systemic vascular resistance. Basically, just know that some murmurs, grades 1 through 2, may be normal for pregnant mommies, and know that previous symptomatic murmurs may lead to clinical decompensation after pregnancy.
All right, Amira, we want to hear you more. That was fantastic. Let's just
that
do
was
a
more than
quick shotgun
fantastic.
review of the valve
That's my
disorders
best friend.
one more
Yeah,
time.
you're the best.
Mitral stenosis. This is a diastolic murmur. Leads to pulmonary edema, pulmonary hypertension, and heart failure.
I really have
Give
the
diuretics
goosebumps.
and arrange operative repair. Mitral regurg. This is a high-pitched holosystolic murmur. Acute mitral regurg is bad news bears. These patients need nitrates, inotropy, and potentially a intra-aortic balloon pump. Mitral valve prolapse. This results in a mid-systolic click and generally is asymptomatic. On board questions, however, patients will generally present with vague anxiety and palpitations. Aortic stenosis. This is a harsh systolic ejection murmur. Critical stenosis. Patients will have dyspnea and syncope on exertion. The literature is constantly changing on how to manage these patients acutely in the ED until you can get them to the CT surgeon's trusty hands. But basically, you don't do much. You just give them O2 and Lasix, maybe some inotropes. What about acute aortic regurg? This is a diastolic murmur. These patients are super sick and do not do well. Provide afterload reduction and inotropy. Do not, I repeat, do not put an intra-aortic balloon pump in or you will kill these guys. Moving on to replaced valves. Bioprostheses like cow valves, pig valves, or cadaver valves
Mary killed it.
fail more often but don't require anticoagulation. whereas mechanical valves fail less but require lifelong anticoagulation. Mitral valves more commonly result in thromboembolism, and so an INR of 2.5 to 3.5 is needed for the mitral valve, whereas aortic valve prosthesis just need the normal 2 to 3 INR goal. Again, bioprostheses fail more often, but don't require anticoagulations. Mechanical valves fail less, but require lifelong anticoagulation. All right, let's just finish with a quick pop quiz. So, patient has a high-pitched holosystolic murmur. What is this? This is most likely mitral regurg. What about a harsh systolic ejection murmur? This is most likely aortic stenosis. What about a mid-systolic click in an anxious patient? That's right. That's most likely mitral valve prolapse. I am diaphoretic and my chest is killing me after those two amazing...
That's pretty cool. Good job. Yeah, you killed that. I was so confused the whole time, and you just knew exactly what you were talking about, and you dropped some lines that got me refocused. That was awesome. Good job. Really good job. That was really good. Miss you.